here. 4 can keep
Third
record.
वाले कह दें वो
Sir, I'll
टाइम
keep the
है.
timer. I'll keep the timer.
Okay, yeah. I'll start here.
Okay, sir. So should I start?
Yeah, I can start.
Okay. Sir, I am provided with radiograph knee of a skeletally mature patient, and the first obvious abnormality I could appreciate is a small fracture fragment adjacent to lateral tibial plateau, likely representing a C-Gordon fracture. In addition to that, I could appreciate mild lucency in the tibial spine, and as I know that the C-Gordon fracture is closely related with with the avulsion of ACL, I would like to confirm this on MRI to see any possible ACL injury and would like to take an orthopedic consult.
So you want to look at the orthogonal image or not?
Yes, yes. I also want to look at the orthogonal images.
What do you want to look at the orthogonal image?
Sir, I want to look at the indirect signs of ACL injury, like the deep sulcus sign. Yeah, sir, I think there is subtle elevation of the lateral femoral condyle. There is joint effusion. Patella is in its normal place. No dislocation is noted. So, sir, these confirm my findings of the C-Gordon fracture, and
Yeah.
I would need a MRI knee for further to see the further associated injuries.
Okay, how you proceed this case?
Sir, I would like to inform the primary. I would like to do an MRI knee. I would like to take an orthopedic consult.
Okay.
Yes, so just start.
So this is your next case.
Okay, sir.
This is patient present with the history of trauma, A&E. Yeah, over to you.
Okay, sir. Okay. Sir, I want to scroll from the top to the bottom, and
Okay,
then
sure.
I'll give opinion. Now I'm scrolling from the start. I'm provided with CT span images, axial view, patient presented with the history of trauma. Sir, I think I could appreciate that there is a fracture of the. No, I think the clavicles are intact. Yeah, the clavicles are intact. I am now looking for any facet joint injury. Sir, on these axial images, I could not see any obvious injury to the facet joints. I would like to see the lateral view. Can I have lateral view? I think that there is some inverted hamburger sign on this level, but I'm not accurately delineate the level, and I would like to see a sagittal bone window.
Okay, sure. Now you can see on sagittal.
Yes, sir. Okay, I am seeing the sagittal images now. I could appreciate that there is a locking of the facet joints seen at mid cervical level. I think it's perching of the facets because it's seen posteriorly. There is retrolisthesis of C7, C7, 1, 2, 3, 4, 5, 6, 7. Yeah, there is retrolisthesis of C7. So it's bilateral facet joint dislocation as it's seen on both sides, and there is at least uh, 25 to 50% enterolisthesis of C6 over C7, and as it's bilateral, so it's unstable, and I would like to inform the primary and would like to take an immediate neurosurgery consult. I would also like to do an MR spine as there is significant retropulsion of the vertebral body, and I would like to see if there is any injury to the cord.
Okay, so previously you say this is a perch facet, now you say the dislocated facet. So this is dislocated or perch?
Sir, I think the facets are bilateral. There is bilateral perching of the facets
Okay.
because at this point they are seem the superior and inferior facet they seem to be touching each other.
Okay. So this is your next case.
Yes, sir. Okay. Sir, I'm provided with the radiograph chest of a patient, and the first obvious abnormality I could appreciate is a retrocardiac opacity on the left, and it appears rounded. Another additional tiny opacity is also seen closer to it. Uh, Otherwise, the lungs are clear. Sir, I would like to know the history of the patient.
Yeah, 40-year male. A patient has no clinical symptoms.
Okay. So, sir, the patient is a 40-year-old male, and I could see a retrocardiac opacity. So, I would like to see this on the CT chest, as it could be in the lung or in the mediastinum. I would like to confirm, and I would like to, for its further characterization. However, I could not see any obvious rib destruction or any other calcification or fat component within this opacity. There are no effusions, just rounded left retrocardiac opacity is seen.
Okay. So you see retrocardiac opacity. So you may think this is maybe in the lung or maybe in the mediastinum. If it's mediastinum, so which
Yes, sir.
compartment will be it?
Uh, Sir, I think it would be in the it's partly obscuring the interior hemidiaphragm, and sir, the aorta and the vertebra are seen clearly. So it would be, I think, it would be present anteriorly.
So what is your differential?
So for interior mediastinal, the differentials would include diaphragmatic hernia, pericardial cysts, but they're mostly on the right. Teratoma, but they show some calcification and the fat levels. And I would also think of lymphoma.
Okay, how you proceed further?
So I would like a CT chest.
Sure.
Yeah. So I'm provided with a non-contrast CT scan of the patient. Um, so I think now it's moving. So I'm moving to my region of interest first.
Mm-hmm.
Then I'll have look at the rest of the scan. Oh, so I could appreciate that there is a lobulated soft tissue density located in the posterior mediastinum. I could see a prominent vessel arising from aorta and supplying it. So, in addition to that, it has significant lobulated margins, and few calcifications are also seen within this mass. So as it's supplied from the aorta, so now I'm thinking of sequestration as my first differential.
Mm-hmm.
And I would like to see if the patient has any prior imaging, and I would like to compare. Uh, Sir, I would also like to see the post-contrast imaging and further refer and discuss the patient in a thoracic MDT.
Okay, what do you want to see on the post-contrast?
Sir, I would like to see if there is any this vessel that is supplying the aorta. I would like to see it clearly as I have seen it in the non-contrast. And
Okay, it's supplying the aorta. Then
yeah. So then the primary differential is sequestration.
sequestration. So how you differentiate sequestration as a type of sequestration?
Sir, there are two types of sequestration. One is intralobar and one is extralobar.
How you differentiate?
Sorry.
How you differentiate between?
So the extralobar, it presents early. It has a drainage into systemic veins. The intralobar, it presents late. It has a drainage into the pulmonary veins. The the extra is associated more with the with other anomalies, and intralobar is less associated. And the intralobar is enclosed within the lung pleura, and
Okay,
the
good.
extra is, sorry.
Okay, very good. So this was your first case.
Yes, sir.
Very nice. You picked the pathology as a
9
second
minutes,
fracture.
33 seconds.
Oh, very good. So second fracture, you pick the curvilinear, yeah, radio density, which is just parallel to the lateral tibial plateau, and indirect sign of the ACL injury, good, and no associated osseous injury. And whenever see the fracture in the knee, always demand orthogonal view to see the FEN. If there is FEN, definitely fracture. If there is no FEN, no fracture. FEN, fracture, no FEN, no fracture. Okay?
Yes, sir.
Yeah. So other thing you have to see lipohemarthrosis. There is a grass, grass suprapatellar FEN, but no lipohemarthrosis. Okay. Again, the same case was shown in my exam, but the injury was the tibial spine injury. Young patient. The examiner asked me what is the finding. The patient presented with in A&E with trauma. That was a young patient. There was a tibial spine fracture. Then abruptly the examiner, oh, maybe ACL injury, because this is a plain radiograph. You say maybe ACL injury. These are secondary features. So I want to confirm this finding on MR. But examiner couldn't give me an MR. So on plain study, try to complete your case. Yeah. MSK radiograph are diagnostic. MSK radiograph, you can give directly diagnosis, but radiograph abdomen and the chest, you give differential. For confirmation of diagnosis, always demand cross-section study. Good. So this is your next case, axial. On axial, finding was also there. If you focus, you see, over this area, the finding is here, yeah. Though articulation is lost between two facet joint, yeah. So you can raise possibility on axial as well. Why I show axial? Because in the most exam, the examiner only show axial images. So if you pick the pathology on the axial, this is again a good point from your side. Exam become happy with you. Even on axial, just raise your possibility. Maybe the history of trauma, maybe there is history, there is fracture, dislocation of the facet, yeah, good. So next one, sagittal, nice. You pick the pathology at there is a in grade 2 anterior thesis along with the retropulsion and the widening of interspinal space as well. And this was actually not a locked facet, actually the perch facet. Locked if the overlap posteriorly, the inferior superior one overlapping, then the inferior one, then this is called locked facet. If the overlapping are just behind, then called as then called purge. But if they see there is slight widening of the facet joint, then called disruption. Okay.
Yes.
So this injury associated with flexion injury or extension injury?
Sir, I think the flexion one.
Yeah, good, very good. Still associated with the flexion one. So on the frontal, good, you pick the pathology. You raise possibility either this one is a intrapulmonary or maybe a mediastinum. So here you see the mediastinum, the heart saluting
Yes.
with heart. So it
Yes.
means the pathology is actually in the posterior mediastinum.
Okay, sir.
You will be very the regarding mediastinal lesion, either the anterior mediastinum or the posterior or middle mediastinum, on plain radiograph especially. Then the other thing is, whenever you see the mediastinal pathology, first comment on which compartment, interior, middle, or posterior, first thing. Second thing, either aggressive or non-aggressive. Maybe some involvement of other thing. Yeah, and they're like, I like your comment that you say there is no destruction, so being non-aggressive. On CT, when I provide you good, you pick that there is aorta supply, suspicion of in sequestration with the peripheral calcification, lobulateral pathology, homogeneous. Post contrast, I tell you there is a supply from the aorta. Then you tell me the differential. So overall, your performance was well, good. You picked the pathology in your first instant, like your first candidate, you both perform well. Best of luck for your exam.
Thank you so much, sir.
So the third candidate,
Assalamualaikum.
Islam. हाँ जी, proceed करें third candidate. Second candidate?
Okay, so this is the chest X-ray frontal projection of a
Yeah,
skeletal.
so sorry, second candidate आप kindly timer set कर लें 15
Sure,
minutes.
sir. Sure.
This is the chest X-ray frontal projection of a skeletally mature patient. I can see that there is bilateral bulky hyla. Other than that, the both costophrenic angles appear normal. I cannot see any pathology, any consolidation or collapse within the lung. There is no pneumothorax. Yeah, so grossly the rib cage as well as the other bones appear normal. So I will be thinking of bilateral hilar lymph adenopathy.
Ignore the hilar region, just focus.
Yes, I can see that there is a in the right cardiophrenic angle, I can see an opacity which is somewhat slitting the right heart border.
Which one?
And this
You
one,
wait, I want to give you control. I can show me. Yeah, wait.
request remote control.
Yeah, you can.
Okay, so I
Wait,
think
wait,
this
wait.
one,
Just wait. Yeah.
this one here.
Candidate 2, you please. I think you're using the mouse now. Please leave it. Yeah. Thank you. Now you can control.
This is my mouse here. Can you see it?
Over here?
No, this is the pathology I'm looking here, this one.
So you can use cursor. Show me.
I'm using the cursor. You can see or not?
No, I cannot see. You
Okay,
can
then
use,
I will just you can, but it's showing that I can. Can I?
yeah.
Can you
No,
see
you
now?
can. Yeah.
This is the opacity I'm talking about in the cardiophrenic
So
angle because I
actually,
can.
this is a normal. This one region is a IVC. Anything else?
Okay, then there is nothing subdiaphragmatic, and other than that, in the retrocardiac areas, I'm looking at my review areas. The apices appear normal, and there is nothing in the retrocardiac region. I'm looking at the axillary regions and the midline. Paravertebral, I cannot appreciate any abnormality.
Yeah, will you please focus on the rib cage?
Okay, so I think there is some expansile lesion involving the eighth posterior rib on the left side, and
Okay.
I would be thinking if this is a young adult, I would be thinking of possibility of fibrous dysplasia, otherwise, or Langerhans histiocytosis. The third differential would be of a brown tumor.
Good.
And I will discuss the findings and ask for
Yeah, the differential. If the patient is old age, you say
old age. Then I will think of metastasis as well and plasmacytoma also will be my differential, multiple
so if
myeloma.
you think mets from which tumor these mets appear like the expansile.
From renal cell carcinoma and also from the lung, but lung is clear in this case. So I can think of renal cell carcinoma, yeah. And
Okay. So how you proceed further?
so for further, I will go for CT chest, abdomen, pelvis of this patient with contrast.
Okay. So this one is your next case. Can you scroll? Just click on screen and use your keyboard up and down keys.
Yeah, okay.
Slowly you can scroll it, yeah.
Okay, so this is the CT axial section, CT brain plane. First, I will just scroll through the images to have an idea of the study. So I'm just scrolling down and from the vertex, and I can see that there is a large right frontoparietal hypodense area. Um, it is heterogeneous with the vasogenic edema noted, and it is causing significant mass effect in the form of contralateral shift of the right lateral ventricle, as well as there is generalized cerebral edema and midline shift suggesting subfalcine herniation. So I'm just going to scroll towards the, yeah. So I can also see that there is yeah, it's involving the temporal lobe as well. And I'm trying to look for any uncal herniation associated with this. So I will just have a look at the basal cisterns. Yes, I can see that there is effacement of bilateral ambient cisterns with the mass effect on the midbrain.
So
So
based on this pathology,
yeah.
what do you think? What will be
Uh,
the...
I'm thinking in terms of possibility of a mass with surrounding vasogenic edema, because I can see that this is this is likely an aggressive tumor.
Mhm.
I'm just trying to see for any areas of hemorrhage within the tumor. Yes, I can. I think I cannot see any obvious hemorrhage here, but most likely this is a aggressive mass lesion.
So
And
other differential other than mass?
other than mass, I would have thought of abscess,
Okay.
and number three would have been of metastasis.
Mhm.
If in my routine practice to rule out abscess, I would have also changed the bone window and look for any evidence of otomastoiditis or any sinusitis.
So
Uh,
based on the location, what do you think? What will be the source? If this you think that may be an abscess, so what will be the source?
I think the source based on this location can be from sphenoid sinus or
Can scroll, yeah.
yeah, okay. So I'm also concerned for tonsillar herniation, and I want to look at the sinuses grossly, so I can see that the sinuses are normal, and yeah, it's okay. So the mastoid ear cells also grossly appear normal. There is no, I think, opacification, and there is no evidence of tonsillar herniation. So this is actually an emergency. I will urgently inform the referring physician regarding the findings and my
So how you
differentials.
confirm that this one is abscess or
Uh,
mets
Yeah,
or
I
primary
will
mets?
arrange. Yeah, I will arrange urgent post-contrast CT for this patient.
So if this one is abscess, how is the appearance of the ring enhancement?
Then also a clinical history will help, because I will see for the any elevated inflammatory markers of this patient, and yeah, fever history is there, or any previous infection history is there regarding any other etiology.
Okay, yeah, this patient presents with a weakness and a fever.
Yeah, so my top differential would be then be of the abscess. If the patient is stable, I will also prefer to go for MRI with
So if
contrast.
this is abscess and patient age is 60, how will you inform the clinician this one the abscess not a mets? What will be the feature of enhancement pattern? Example, the
Yeah.
clinician is worried about maybe patient have brain mets.
First of all, based on this CT you are asking me, na?
Yeah,
Okay, so first of all, there will be a ring enhancement. Number two, usually mats present with the multiplicity of the lesion,
okay.
and the third thing is the history that favors, and also the enhancement pattern of the abscess is such that I think the medial wall is usually thin and the lateral wall is more thick as compared to the medial wall.
In the mets
No, abscess.
and in the mets.
Mets will have a thick nodular irregular wall enhancement, peripheral. They can have peripheral enhancement, yes.
Okay.
And also I will look for any other like dural venous, cerebral venous thrombosis, which is a complication associated with abscess formation.
Okay, I'm just giving you So what is study?
This is, I think, this is a gray scale on the left side of ultrasound. And on the right side, I think it's elastography. No.
So this is a contrast enhanced ultrasound study.
Okay.
Okay. Now you can scroll and tell me the finding.
Okay, so on this provided study, I can see that the liver shows, liver is heterogeneous, showing multiple lesions within it, which are hypoechoic on the, which are hypoechoic on,
Which one you are asking? Just
this is
show
not
me.
moving anymore. Okay.
Okay, you can proceed. Yes, scroll the study.
These are hypoechoic. These lesions are hypoechoic. And on the post contrast, I can see.
Just scroll the study. Just first, then comment on. Yeah.
But I don't know. It's not properly.
Okay, just I think scrolling. Yeah, you can scroll.
It looks like as if it is stuck, not scrolling properly.
Okay, just wait. I'm scrolling for you.
Okay. Okay, so I can see that these lesions are enhancing on the post-contrast ultrasound study. And are significantly
First complete your
enhanced.
study, then make a comment.
Sorry?
First complete your study.
Okay. Okay, so I can see that there is ascites and associated, and I can see that in the hepatorenal pouch, I think I saw a soft tissue. I'm not sure about that.
Okay, what are you finding on the contrast enhanced ultrasound?
I can see that these lesions are enhancing. So likely these are metastatic lesions.
No, with the pattern of enhancement.
Pattern of enhancement is there is complete enhancement of the lesions.
No, this is which phase you're enhancing? This is arterial, venous, delayed.
Actually, sorry, I've never before done contrast enhanced ultrasound. So I think this is arterial, but I'm not sure.
Okay, so show enhancement. You think maybe arterial, then what is your differential?
So I will be thinking of possibility of vascular mets. And so that would be in keeping with the primaries I would be thinking of would be renal cell carcinoma or carcinoid tumors.
Other differential?
Sorry?
Your other differential?
Other differential I would think of is, yeah, if they show a washout also, then I would think of multifocal HCC, hepatocellular carcinoma. And
okay, I'm giving you a CT. You can make comment on the CT. Yeah.
Okay. The same patient?
Yeah, same patient. Wait, just you can scroll it. Just wait. Yeah. No, you can scroll it. This is an arterial phase. Yeah.
About 14 minutes ago.
Okay, scroll it.
Okay, so this is the exact section of the CT post-contrast AR arterial phase, and I can see that okay. Okay, so I can see that in the liver there are areas of arterial blush, and the liver, however, appears to be smooth, regular margins. I cannot see any area of any finding of cirrhosis. And I would like to see the liver further. I can see areas of arterial enhancement. I would like to see further the portovenous and the delayed phase also.
So
There is
this
no
one,
significant.
this one is the portal phase.
I need to click this.
Yes, I'm scrolling for you. No time factor. I'm scrolling for you.
Okay. Okay, so on the portovenous phase, there is washout. So based on these findings, I'm thinking in terms of hepatocellular carcinoma as my
What
top
about the
differential.
margin of the liver? Is appear normal or this is cirrhotic?
No, the liver appears fine to me.
Then what do you think? If the liver is normal, what is other differential?
Yeah, if the liver is fine, I would think of um, possibility of adenoma also shows early enhancement and then, but it does not show washout. Met,
Okay.
yeah,
Okay.
metastatic disease process. Yes, I can
So
think of.
here in the abdomen, any other finding you see?
Yeah, I think I saw the right adrenal. Yeah, in the left kidney, I can see, and the right adrenal, I can see there are some mass lesions. And I would be suspecting left renal mass with possibility of this metastatic disease process.
How you
Um,
proceed further?
I will inform the referring physician and ask for the biopsy of the this one liver hepatic lesion. Uh, and for the I also discussed with the nephrology team in the MDT for the renal mass because it has to be excised. And yes, I will check for the other distant metastasis bone scan for any bony pathology.
Okay. So regarding your feedback, so this was your first case. So here, you say this one expansile lesion, lytic expansile. Then you give differential of the fibrodysplasia or METs, maybe a brown tumor. Yeah, the differential good, but in your first instance, yeah, you couldn't pick the pathology with the assist, and then examiner give you hints, then you pick the pathology. Okay, good. So your differential, okay. So okay, fine. This case on your next case, I gave you CT plane. Try to focus on plane study. Yeah, you described all the finding and see there is a large mass lesion. Yeah, along with grass with an edema, and then I asked you what will be the cause, whatever differential you gave METs or brain abscess, and other differential was maybe a primary. So this was an old patient, maybe a abscess, then if enhancement pattern, you told the enhancement pattern, it show fine enhancement, and on the METs, it show irregular nodular enhancement. Very good. This is very important. Just seeing on the enhancement pattern, you can describe whether this on the METs or not. But in the old age patient, you think maybe a MET. Yeah. So wait. Yes, left. Please leave the mouse. Who is using mouse? Yeah, so mass regarding the mass effect and brain abscess, this is you have to refer this patient to the urgent A&E for drainage, and because there is a midline shift and there is large abscess, the history indicate that patient this one is likely a brain abscess. So in your next case, why I show the contrast in ultrasound? Because contrast in ultrasound was shown me in my exam. So be familiar with this case, can be shown in exam. So in the first look, you see no enhancement seen on the liver. If any lesion is showing enhancement in the early phase, it means this one is the arterial phase. And if the early enhancing lesion, definitely these are the arterial enhancing lesion. First thing. Second, so how you differentiate portovenous phase is, see, the liver parenchyma showing enhancement. So when the liver parenchyma is showing enhancement, so it means the portovenous or venous phase. So this is a very easy trick. You can easily grasp the lesion. Okay, candidate 3.
Yes, sir.
So this can be shown. Same case was shown in my exam. So okay, very good. You pick that artery enhancing lesion, the liver was normal, and the washout, and the kidney left side nephrectomy, and again right adrenal lesion, good. So maybe a renal mass with enhancing artery enhancing hepatic mets. Yeah. So you have to refer to MDD. If the previously known, then they will be known, then change the regime. Okay. Who is the next candidate?
Okay, thank you so much.
Yeah.
Assalamu alaikum, sir. So should I start?
Can who will set the time?
Anyone?
Okay, 15 minutes. Please set your time.
Yes. So I've been presented with the X-ray hands, bilateral X-ray hands, in which I can see there is loss of joint space as well as erosions, predominantly involving the distal interphalangeal joints. And there are periarticular erosions, and there is a possibility of girls weighing appearance that is more seen in the left hand, in the middle finger, in the distal
Okay,
interphalangeal joint.
good.
And the proximal interphalangeal joints appears to be slightly involved as well. However, the carpal or metacarpal joints appears to be swayed, and there is generalized decrease in the bone density. Apart from that, seeing at the wrist joint, I'm not able to see any abnormal calcification. There is dense failings noted in the thumb of the left hand.
Left, right.
Right. The right metacarpal of the right hand appears to be sclerosed and slightly expanded and appears and apart from that, I'm not able to see any other abnormality. Looking at these abnormalities, my first differential is actually psoriatic arthritis with sausage finger as well in the metacarpal. I would immediately inform these findings to the referring physician and compare these X-rays.
Your
Yes,
other differential.
sir, it could be erosive arthritis and other differential, very less likely rheumatoid because they involve first the carpal and the carpal bones. And
Regarding, I'm just focusing on this
yes,
metacarpal.
sir. So erosive arthritis could be a differential, and Reiter's can also be a differentials, and less likely rheumatoid arthritis, but first will be psoriatic.
So this you see the sclerosed metacarpal of the right
Yes, sir.
thumb. Then what your other differential? First differential was psoriatic, and you say sausage
Yes, sir.
finger. I think this if you see both thumb are comparable in size. So what do you think other than this psoriatic arthritis?
Sir, if you're considering just a thumb or you're talking in general,
I'm just
sir,
focusing on this thumb.
sir, it can, looking at the sclerosis and expansion, I can think of solitary spina ventosa, but also it gives more of a lucent appearance. Apart from that, I can this sausage digit is also seen in it can be a single sclerotic met in the hands.
Okay.
It can be other sclerotic lesions like so less likely fibrous dysplasia.
So you
But
say fiber dysplasia. What is the appearance of the matrix in the fiber dysplasia?
they're ground glass matrix, but considering the other associated pathology, it is very less likely.
So you say this is the axis. This one is actually expanded.
Yes,
So
sir.
while considering the expansion, what do you think? What will be the cause?
Um, Sir, actually, the underlying pathology related to the sausage digit, you're asking?
No, I'm focusing about just the sclerosis of this metacarpal. Yeah. What is your differential? First, you say what is it called as this failing, this metacarp call if this scleral
sausage digit.
sausage.
Dense.
I think both. If you compare both thumb, their thickness, I think appearance is comparable. But
Yes,
this
sir.
you say this is the cortex expanded. Okay, I'm agree with your finding that is cortex expanded. And if you focus on the trabeculae appear normal or there is coarsening.
No, sir, there is coarsening.
So is the
There is a
coarsening and the
central areas
thickness.
of lucency. It can be, but although I'm not able to see any periosteal reaction and bone erosions, it can be as septic as well, septic etiology. But
Septic,
I'm not sure about that because I'm not able to see any associated periosteal reaction or soft tissue expansion. It can be a sclerotic met, sir. It can be a metastatic. And so apart from that, I am able to appreciate a few other erosions in the metacarpophalangeal joints as well in the
okay,
right hand in the fifth head.
I'm not interested in the degenerative
Okay,
changes.
so rest of
Yeah,
yes, sir.
yeah. I'm just interested on this, Lian. Okay. Move to the next case.
Yes, sir.
So this patient present in A&E.
So should I
There
ask
history
for
of trauma. Yeah, I'm just giving the control. Just let me wait.
the requested?
Yeah.
So I have been
Just
presented
click
with
on
the
the
CT.
just click on the screen. Then you can use mouse. Then your keyboard up and down, please.
Yes, sir. I've been presented with the CT axial images, non-contrast scan, in which I would like to first scroll to the whole stack and then comment. The first abnormality that catches my eye is actually the hyperdensity noted along the tentorium cerebelli. Apart from that, there is a dense basilar artery noted in the circle of Willis.
Okay, ignore it.
Sir, as it is a case of trauma, so I am first searching for any subdural, extradural, or subarachnoid hemorrhages.
Okay, good.
Although I'm not able to appreciate any acute or subacute hemorrhage. There is subtle hypodensity noted along the frontal horn of the left lateral ventricle,
Okay,
rather bilateral.
Ignore it.
Yes, sir. Yeah, I'm not able to appreciate any loss of gray-white differentiation. I would like to see the insular ribbon area. Which appears normal to me, but I would still like to see it in the stroke window as well, because sometimes the very, very early stroke secondary to any trauma is not appreciated well.
Okay, anything else?
Sir, apart from that, I see this hyperdense area noted along the tentorium and the dense basilar artery, slight prominence of the temporal horns.
So tentorium, you think maybe temporal thickening of temporal or other, maybe a hyperdensity. What do you think then?
Sir, I am suspecting that there might be some underlying hemorrhage.
Okay, how you confirm that?
Sir, I would like to do MRI. If the patient is stable and still on the bed, I would like to confirm this on MRI.
So MRI is very, the time consuming for on CT, the patient is A&E. You
Sir,
have to
contrast enhanced studies will also delineate any subacute or hematoma if it is there. And CT angiography could also be helpful if there is any evidence of any rupture of any aneurysm if there was present before.
So you think maybe tentorial, something in the tentorium? How you confirm on the CT?
Sir, if I can see the coronal images.
Sure.
Yes, sir. Again, I can appreciate the hyperdensity noted around the right tentorium. I'm not able to count. Yes, sir. There is a subtle, there is a convex area noted along the tentorium cerebelli on the right side. That is most probably an subdural hematoma without any intraparenchymal extension, and it is slightly effacing the underlying gyri and sulci. So I would immediately inform this to the. So I would first see the bone window to see any associated fractures, and
Sorry,
inform
bone
my
window is
finding to the
not
referring.
available. Okay.
So I would inform the my findings to the referring physician and take the neurosurgical consultation for this urgent neurosurgery consultation. Although I am not able to appreciate any gross tonsillar herniation, midline shift, or mass effect, but there is subtle prominence of the temporal horn. So it may lead to further obstructive hydrocephalus, and so it should be there should be urgent neurosurgical consultation for this patient.
So how you recommend
And
to the referring clinician?
sir, I will inform the findings, and I will ask if the patient is stable, I will ask for the MRI. And if the patient condition is not stable, I will ask for the neurosurgery consultation for this patient for the management and treatment.
Okay. So this is your next case.
Sir, I've been presented with the ultrasound of the left testis. Sir, is it a static image?
Yeah.
In which I can see a heterogeneous texture of the left testis, a heterogeneous echogenicity, with increased vascularity that is noted within the parenchyma. I would like to know I would like to measure the size, and I would like to know the history, if there of any pain and swelling, and then my considering that this radiological image, my topmost differential will be orchitis.
Yeah, the patient
Of
present with a history, patient age is 30-year male and testicular pain.
Yes, sir. So it looks like it is giving a picture of orchitis. And I would inform this because there is no associated hydrocele, and there is no associated there is vascularity is intact. Rather, it is increased in the given picture. So the
The
first
other
topmost.
differential.
So other epididymoorchitis. And so I am not able to visualize any underlying mass, well-defined hypoechoic mass. So testicular CA will be a lesser differential. Yes, sir. Here I can see the epididymis as well as the testis, in which I can see again the redemonstration of the heterogeneous echogenicity. So, sir, I would inform this to the referring physician, and I would like to recommend MRI for this patient if there is any history or suspicion of testicular CA before. But considering the radiological findings, it appears more of a orchitis because of the striated appearance as well as the heterogeneous echogenicity, and increased in the size, most probably.
But this patient has the pain since 2 to 3 months.
Sir, then the possibility of underlying carcinoma or malignancy should be considered. And I would like to advise.
Which one you are thinking? Which one?
Sir, seminomas are normally hypo-enhancing, like hypoechoic, sorry.
Okay, so how you proceed further this case?
Sir, I would like to recommend MRI
What do you
to
want
see
to
the
see on
enhancement
MRI?
pattern. Sorry, sir.
What you want to see on MRI?
Sir, I would like to see for the different further evaluation, and sir, I would like to first characterize it on MRI on the multi-sequential way, by seeing the various images as well as the post contrast and the diffusion restriction, to further characterize that whether this is just an infection or it is related to some malignancy. and take the history. And if it proves to be malignant, then I will further recommend for a CT cap for the staging, and recommend this to the urology and oncology MDT for the further management.
Okay, CT abdominal paralysis performed. Now you can proceed.
So I've been presented with the CT abdomen and pelvis, in which I can see a large, most probably a nodal mass that is noted in the aorto, in the left side of the abdomen in the retroperitoneum.
Mhm.
That is a big nodal amalgamated mass.
Mhm.
And considering the previous ultrasound examination and this nodal mass, and also an enhancing mass like lesion in the left scrotum, the first probability is actually of malignancy
Mhm.
with associated nodal masses in the para-aortic region.
So what do you think? This nodal mass, are this one is the associated with tumor or the mets?
So these are metastatic, because this is the prime site of drainage for the testis. So these
So
are
this
actually
one
the
is the regional
nodal
lymph node or
metastatic
these are
masses from
mets?
the testis.
These are regional lymph node or the
So,
mets?
so these are regional.
Regional lymph node.
They drain here. The testis drain into the para-aortic lymph nodes.
Okay.
Sorry to disturb, sir. 15 minutes are gone.
Okay, thank you so much. This was your last case. So this was your first case. Very good. Just you described the arthritic changes. So actually there is a distal polyarthropathy involving the mid and distal interphalangeal joint. Yeah, but I think the most important is this one, this pathology. So you described that there is actually sclerosis, expansion, and few coarsen of trabeculi. So your differential was psoriatic arthritis, okay. Other differentials you told, but the main thing in this case, see the cortical expansion, cortical thickening with coarse trabeculi. So in which disease these things are present? Candidate 4.
Yes, sir. Sorry.
In which disease these features are present? There is thickening of the cortex, coarse trabeculi, and cortical expansion.
Sir, mostly in the uh, is some blood-related disorders like thalassemia,
तो
leukemias,
just आप
but
माउस
they
को
are not.
allow कर दें, माउस को छोड़ दें काइंडली,
जी सर,
या
सॉरी।
लीव द माउस। इसमें ना देखें कि ये जो है ना पेजेंट डिजीज का केस है, ठीक है। तो
सर,
या तो इसमें आपको आइडिया होना चाहिए, एक तो कार्टिकल थिकनिंग, कोर्सनिंग का ट्रेबिकुलाई एंड एक्सपेंशन। कंपेयर करें दोनों मेटाकार्पल्स को, तो इसमें देखें एक्सपेंशन है इसकी ज़्यादा, ठीक है। शाफ्ट की देखें, और कार्टिकल थिकनिंग भी है और कोर्सनिंग भी है, तो ये क्या है, पेजेंट डिजीज
पेजेस।
है। या तो मुझे पहली दफ़ा जब पेजेंट दिखाया गया ना एग्ज़ाम प्रेप उसमें प्रिपरेशन में, तो मुझे पिक नहीं हुआ था। तो उसमें डॉक्टर सजाद भट्ट साहब थे, उन्होंने मुझे सारा फिर समझाया था पेजेंट। तो इसमें ना आपने जब भी पैथोलॉजी देखना लियन, अब एग्जामिनर आपको कहा कि ना आई एम इंटरेस्टेड इन दिस लियन, तो आप रेस्ट ऑफ चीज़ों को सारी भूल जाएं। इट मीन के मेन थिंग इज दिस वन, तो आप उसको फोकस करें और देखेंगे इसमें और क्या क्या है। अब आप जब भी देखें पैथोलॉजी इसमें ना एमएस के लिए और रेडियोग्राफ पे, आपने उसके सारे फीचर बताने हैं। नो कार्टिकल ब्रेक इज देयर, नो फ्रैक्चर इज देयर, नो पेरियोस्टेशन इज देयर, तो ये सारे फीचर हैं, करीबन 9-10 सारे, इसको रिकॉल करने हैं। अब लोकेशन बतानी है, स्केलेटन बताना है, मेच्योर है, मेच्योर ऐसे ओल्ड है, तो ये पता लग गया। बाकी बताना है आपने इसकी मैट्रिक्स कैसा है, तो ग्राउंड ग्लास तो बिल्कुल भी नहीं है, तो उसमें आप फिर अब देखें मल्टीपल केसेस ग्राउंड ग्लास किस तरह नज़र आते हैं। Sclerotic and good to give differential of meds. I agree. But the differential was patient disease. Your approach is very good. आप जैसे अपने अप्रोच किया ना, सारी चीज़ें डिस्क्राइब की, वेरी गुड, वेरी नाइस। तो डिफरेंशियल वो करने होते एग्जाम में ना, examiner doesn't want from you an expected diagnosis. Just you give your differential and tell either this is aggressive lesion or non-aggressive. This is very, very important. ठीक है। तो डिस्क्राइब आपने
जी
सारा
सर।
ठीक किया, तो उसमें मैं यही बताना चाह रहा था कि ये जो है ना पेशेंट का केस है, बट योर डिफरेंशियल आई एम एग्री विद योर डिफरेंशियल, मे बी psoriatic arthritis or mets or पेशेंट डिजीज।
जी सर।
तो उसके बाद ये अगला केस था आपका। अच्छा, आपको जब भी ना देखा, आपने पहले पहले बोल दिया था कि मुझे ना हाइपरटेंसी नजर आया टेंटोरियम में, ठीक है। फिर आपने सारा ब्रेन देखा, फिर आप ना आप देखने लगे कि शायद इन्फाक्ट ना हो। तो अब आपको एग्जामिनर ने हिस्ट्री देखनी है ट्रॉमा की, तो फटाफट देख लें, आपको कोई नज़र नहीं आ रहा ग्रेवर मैटर जनरल लॉस, तो उसको इग्नोर करें। और आपने पहले ही पकड़ी थी ना बाकी गुड, तो आपने पहले उसमें पकड़ लिया था। बट यू हैव टू कंफर्म दिस। अब सिंपल इज, यू हैव टू कंफर्म दिस ऑन कॉर्नल। आस्क एग्जामिनर, आई वांट टू सी कॉर्नल इमेजेस। तो okay, good, you pick pathology on the cornel. This sliver of subdural acute bleed along tentorium, right leaflet. So immediately inform to the EA team. Yeah. So in this case, this one is actually small amount. These people do follow-up imaging. I have also follow-up image. So here in this follow-up image, see, this is gradually increasing.
Yes.
Though the people do gradually see either this is a progressive or this is a regress.
सर जो पहला वाला केस था वो, अगर सपोज करें आप फाइंडिंग सही बताएं और आप मेन डायग्नोसिस जैसे ना बता बोले, आपके मुंह से ना निकले, तो वो फेल हो जाता केस?
नहीं, फेल नहीं होता। एग्जामिनर आपसे ना आपकी अप्रोच चेक करते हैं, ठीक है। तो
जैसे
इसमें
मेरे
क्या,
मुंह से पेजिट्स नहीं निकला सर उसमें,
कोई
तो
बात,
वो
वो डिफरेंशियल ठीक
उसमें।
था आपका, तो वो उसमें सारी चीज़ें हमने
ठीक
सही
है
बताई है, ठीक
जी
है।
सर।
तो उसमें कोई वो भी नहीं था कि कोई इमरजेंसी हो, तो उसमें आपने इमरजेंसी को मिस की हो। बाकी आपने जो एग्ज़ाम में FRCR में ना आपकी, आपने बताया जो है ना रेडियोग्राफ के बारे में बताया, क्या क्या फीचर्स बाकी चीज़ें बताई, तो आपने वो नंबर हर चीज़ के अलग डिफरेंट नंबर हैं। तो जब आपने ये पैथोलॉजी ये भी बता दी, तो आपके नंबर तो मिल गए। अगर आप डिफरेंशियल बताया, आपको मिल गए। तो जब आप पहुँच तो गई, सारी चीज़ें बता दी, तो मेन डायग्नोसिस बता, अच्छी बात है, बट यू गिव द डिफरेंशियल अगेन, गुड थिंग, पास तो है आपका। उसमें ये होता है कि
जी
फिर
सर।
वो आप, क्योंकि न्यू सिस्टम है, पिछले वाले सिस्टम में ये था कि अगर आपने कोई इमरजेंसी मिस नहीं की, तो आपने डिफरेंशियल बता दिया, गुड, आप वो केस पास है आपका एटलीस्ट। नहीं, आपकी डिस्क्रिप्शन बहुत अच्छी थी, मैंने आपको पहले बताया। आपने जो जिस तरह केस को किया ना, बहुत अच्छे तरीके के है। जब भी केस मिले ना, आपने पहले क्या करना है, जो केस को देखना है। आई वांट टू सी यू दिस, आई एम प्रोवाइडेड विद द रेडियोग्राफ फ्रंटल प्रोजेक्शन ऑफ द बोथ हैंड्स। फर्स्ट आई विल सी द स्टडी, डिस्क्राइब माई फाइंडिंग। 2 3 5 सेकंड आप टाइम लें, कोई क्योंकि आप, आपका पहला केस है ये, पहले केस में ज़रा बंदा नर्वस होता है। टेक योर टाइम, तो उसके बाद आप स्टार्ट करें, इसमें कोई मुश्किल बात नहीं है, ठीक है। एग्ज़ाम में जब मेरा एग्ज़ाम था ना, तो एग्जामिनर मुझे गपशप की मुझसे, उसके बाद मुझे 15 20 सेकंड दिए। उसने मुझे, ओके, आर यू रेडी? यस, आई एम रेडी। जब मैंने रेडी कहा ना, फिर एग्जामिनर ने केस स्टार्ट किया, ठीक है। तो पहले आप आएँ,
जी सर।
अपनी एनर्जी बहाल करें और केस देखें। उसके बाद कहें ओके, आई विल टेक फ्यू सेकेंड, आई रिव्यू द स्टडी, फिर उसके बाद स्टार्ट कर दी, कोई बात। ठीक है, लास्ट केस आपका ये था। तो इसमें है एक्चुअली, इसका डिफरेंशियल है, बट इसकी अपेयरेंस अगर आप देखें, और उसमें रिएक्टिव चेंजेस होती हैं आर्काइटिस में, तो इसमें वो रिएक्टिव चेंज नहीं थी एक तो। और दूसरा, आप रेज कर सकती हैं पॉसिबिलिटी ना ट्यूमर की, एज
जी
उसकी
सर।
देखें। हाँ, आर्काइटिस जो है ना, आप देखा होगा अर्ली एज में आते हैं। ये जो 15 से 20 साल की एज है ना, एक्यूट हिस्ट्री होती है उसमें। तो वो जो है ना आर्काइटिस में, उसमें टोरियन में आर्काइटिस। और बट ये क्योंकि इसकी एज ज़्यादा है, तो आप सस्पिशन रेज कर सकती हैं। बट फर्दर फिर एग्जामिनर आपको मज़ीद कोई ना कोई हिंट्स देगा। तो फर्दर इमेजिंग में यही, क्योंकि इसके रीजनल सप्लाई है, तो ये आपने जो है ना फिर देखना है इसको एबनॉर्मल। मुझे तो ये सेम केस मेरे एग्जाम में लगा था। तो सही थी सारी, मुझे पहले अल्ट्रासाउंड दिखाया, उसने सारे मुझे दिखाए। ये मेरा पहला दूसरा केस था वायु में ना। तो सारी चीज़ें मुझे दिखाई, तो मैंने उसको डिफरेंशियल सारे दिए। मैंने कहा ओल्ड एज है, तो मैं इसको पहले मेट्स बनाऊंगा, लिम्फोमा। अगर यंग है तो मैं इसको पहले मेसेमिनोमा। फिर उसने मुझे सिटी ब्रोंकाइटिस दिखाया, वही सारे लिम्फ नोड थे। तो मैंने लिम्फ नोड बताया उसने। तो उसने कहा कि मेट्स हैं कि नहीं, मैंने कहा नहीं, मेट्स नहीं है, रीजनल सप्लाई है। तो ये गुड अप्रोच, ठीक है आपकी। बाज़ दफ़ा ना ये केस भी दिखाते हैं एग्ज़ाम में कि सिटी एब्डोमिनल पैलेस होती, कोई फाइंडिंग नहीं होती, जस्ट द एज ऑफ द फिल्म। जैसे एंड पे जाते हैं, वो स्क्रोटल मैच पड़ा, ये टेस्टिकुलर मैच पड़ा होता है। तो इसका भी आपने ना ख्याल रखना है कि ना शायद सिटी एब्डोमिनल पैलेस में कोई फाइंडिंग नहीं है, जस्ट एंड पे किए तो एजाज फिल्म के ऊपर पैथोलॉजी में। ओके, तो कोई बैकअप कैंडिडेट है कि
थैंक
नहीं?
यू। तो डॉक्टर उम्मे कुलसूम या डॉक्टर बुशरा शायद हैं।
वो बैकअप कैंडिडेट है?
नहीं सर, आई डोंट नो वेदर दे आर बैकअप।
Dr. Kaleem, backup candidate, candidate 3 was basically not there, so हमने candidate 3 उनको लिया था।
अच्छा, उनको लिया था, तो वो कैंडिडेट 3 वापस आ गया?
कैंडिडेट 3 नहीं आया आई थिंक, बट उसकी जगह हमने एक बैकअप कैंडिडेट लिया था, तो उनका वाइवा हो गया।
ओके ओके ओके, चलें ठीक है, थैंक यू सो मच।
थैंक यू सर।
कि क्वेश्चन क्या है इनके? क्या नहीं पार्टिसिपेट, ये कौन है? डॉक्टर आमना हमीद। ओके डॉक्टर आमना, ही एक केस पड़ा हुआ है, आप आ जाएं। कैंडिडेट 3 थी डॉक्टर आमना हमीद। ओके, डॉक्टर वहीद खान, डॉक्टर वहीद खान है इधर? ओके, थैंक यू सो मच।
Dr. Waheed is now the co-host.
ओके, थैंक यू सो मच।
Yes, I'm now unmute. Thank you for muting me.
ओके, थैंक यू।